I take the opportunity to welcome everyone who already joined. Thank you very much, particularly for those who all now tuned in, but of course also and mainly to Axel, who is not only the first speaker, but also was instrumental to launch this webinar series, which we plan to now do every 2 months at least over the next few months. And the goal is, to join, let's say, of course, the people in Switzerland, but as we already can see also people from neighboring countries, Europe, but even international. So that's very good, and let's see where it goes to. We have several topics discussed. Today, Axel will talk about how to select a sarcoma treatment in 2020. I think it's needless to explain who Axel is. I mean, he is one of the eminent contributors in sarcoma care worldwide over the last decade. You and your colleagues, we just heard Jean-Yves Play also from France, you made just a huge contribution, and you dedicated, let's say, your life to sarcoma, and you changed the lives of so many patients. And I think everyone is also grateful, and it's also a tribute to you and to everyone who contributes. Maybe some housekeeping issues for the presentation. Please mute your microphone so that we are not interrupted, and please open your camera. Again, we can speak freely with each other, and whoever speaks is shown on the screen. And I think we let now Axel to, again, someone is very noisy. It would be good to really mute the microphone so that Axel can really speak freely and without any background noise. And when he will be done with his talk, then we have an open discussion, and you are free then to ask all the questions. So if they're all okay, then I think I give the word to Axel, and just tell if you are interrupted that we should again mute the microphone. Axel, thank you so much for being here.
Many thanks, Bruno. Many thanks for your kind wording. I would prefer to give a lecture in Switzerland than in front of my parking of the Sabroussi in a cloudy. But the virus era is not avoid this kind of meetings, so maybe next year. So the challenge today is to try to share with you how to select treatment sarcoma in 2020. I try to highlight 10 different items. I would like to share this item with you. Next slide. So, next slide. So in the field of sarcoma, we have that. We have that today. We have more than 100 histological subtypes of sarcoma, a lot of different biological pathways, a lot of specialists, non-specialists. It's a rare tumor, rare neoplasm. So we have that, and we want, next slide, we want that. So it's a real challenge to take in charge a soft tissue sarcoma patient in 2020. The reality is between maybe these two slides, but we have to optimize the take in charge of patient sarcoma as much as possible. So next slide. So how can we proceed to try to have this slide? First of all, I think you all agree with that, with an initial correct histopathological diagnosis. It's a key point when you take in charge of a patient. You have to have correct diagnosis. So it's a real challenge in this neoplasm with more than 100 histological subtypes. Next slides. So I think you are aware on this slide, we have in France a network since 2010. Now we have 10 years of evaluation of the double review of all specimen. So we obtained the exhaustivity, more or less the exhaustivity in 2017 with 91% of new case review systematically in referral center in France. And the most important thing is on the right part of this slide. It is a discordance between local pathologists, non-specialists in sarcoma. It is the blue curves. When a pathologist in a non-referral centers have a diagnosis of sarcoma, they send the blocks to referral centers, and as expected, we have 1/3 of major discordance. Major discordance means I think it is a sarcoma, but it is not a sarcoma. It is a lymphoma, a carcinoma, melanoma. So major discordance means that, not liposarcoma versus leiomyosarcoma, or a suspicion of sarcoma and it is a benign tumor. It is major discordance. The wrong thing, it is the red curves, the red bar. It came from so-called referent pathologists, so old pathologists before 2010, 60 years old, professor of pathology. I know it is a sarcoma. It's not useful that I send my slide to a referral center. And now it is mandatory. If even in this referent hospital and so on, they send to the referral sarcoma centers the block, and there is 10% of major discordance. 10% every year, you see here. So it means we have to review systematically all in referral centers with a referent pathologist, all new diagnosis of sarcoma. And when you see here the economy, when you made a review, we make an economy of 1 million euro, and we modify the strategy of the patient. And when we modify, of course, the diagnosis. So it is one of the major issues of this network in France. Now every there is, if I remember correctly, 800 pathology centers in France. So now when there is a suspicion of sarcoma, they send systematically the block for review. Next slide. And I share with you the last 2019 review. You see here we have a review more than 6,000 new cases in this network in 2019. 59% of these cases are sent by outside network, and 35% of these cases, there is a modification of the strategy based on the review of the specimen. So it is exactly the same thing in pediatric sarcoma. So it is really mandatory to have a systematic double lecture in sarcoma. Next slide. And just a slide to show, even when a sarcoma case were assessed by an expert pathologist, we made molecular genetic testing in liposarcoma, in desmoid tumor, in GIST, in translocation-related sarcoma. And molecular genetic testing can provide relevant information in up to 1/4 of patients with soft tissue sarcoma. So it's a very, very important issue. We have referral pathology centers in each country, even in Switzerland, Austria, and so on. It's not a so easy diagnosis. Next slide. So another item is very important is to, before treating the sarcoma, we have to discuss files of the patient with patient or only with files in multidisciplinary tumor board, especially for localized disease, because in this situation we can cure the patient. And 90% of soft tissue sarcoma have no metastasis at diagnosis in the database in France. So it is, I think, the same range of patients worldwide. 90% of patients with a sarcoma have a localized disease at diagnosis. So it's very important to discuss in multidisciplinary tumor board all these files. Slide. Next slide. And next slide also. Next. I think you are aware of this recent data published by Jean-Yves. No, before. Slide before. Before, yeah. You see here the two curves of progression-free survival. On the left, between 2010 and 2014, based on 12,000 new incidence case. It is a presentation, the different curves based on the presentation or not to a multidisciplinary tumor board before treatment. When you present the files with a localized disease before any discussion, before any surgery, you increase local relapse-free survival and relapse-free survival. It is due to the increased number of patients underwent another resection. When you discuss case per case, all the patients. Next slide. And today, with more than 25,000 people discussed from 2010 to 2018, surgery performed in NETSAC centers was correlated with better outcomes, not only in relapse-free survival, but also in overall survival. So it's very, very important issue to discuss patient with a localized disease with a potential curative soft tissue sarcoma situation, to discuss the patient and the different strategy according to the presentation before any surgery. In other words, it is important to have the diagnosis of sarcoma before any surgery performed. Next slide. And you have the last number in 2019 in the NETSAC networks with more than 4,000 new patients discussed in multidisciplinary tumor board. You note here the objective we discuss in half of the patient before surgery. And it is the best way. If you want to discuss induction treatment, preoperative radiation therapy, or preoperative chemotherapy, or whatever, including in clinical trials, the best way is to discuss the strategy when the tumor is non-operated. You can discuss, of course, after surgery, but the impact on overall survival is better when you discuss before surgery. It is only a question of resectability. You increase the number of R0 resection when you discuss the patient before any surgery. Next slide. And on the database of National Cancer Database in US, you see here, the R0 resection is a more important powerful prognostic factor to increase outcome of this patient, or whatever the treatment you propose before surgery, radiation therapy, or whatever. So next slide. The primary endpoint for each localized soft tissue sarcoma, it is another resection, a prerequisite for cure. The incidence of other resection increase when the files is discussed before surgery. I think you all agree with that. Next slide. Another issue, it is in advanced disease. We have, of course, the vast majority of patients, especially in high-grade soft tissue sarcoma with a localized disease, relapse with metastatic involvement. And when you take in charge a patient with an advanced setting in frontline, you have to define a correct endpoint issue. Next slide. There are now 10 different randomized trials comparing doxorubicin versus combination doxorubicin ifosfamide. I think you are all aware of the results. There is no difference in terms of overall survival favoring the combination regimen. So we have to define two situations: palliative situation, totally non-operable situation, and we have to favor doxorubicin alone. When the objective is to try to render operable a patient with isolated lung metastasis, for example, we have to favor high-dose regimen because the objective is to try to cure the patient. So it is a reason why when you read the paper in the literature in advanced situation, you add carrots and tomatoes. There is two different, totally different issues, two different tumoral situation. So the objective maybe in the next future is to randomize patient only based on patient issue. Next slide. I heard a lot of things. Next slide. Next. Yeah. Here you have the evolution of the relapse when you follow a patient with a localized disease. So it is an adjuvant trial when the patient when you operate a patient here on day 0 and you follow the patient carefully, there is clearly two different situations. Patient relapsing very shortly within the 2 years following localized resection, and it is a vast majority of the patients are high-grade sarcoma. Vast majority are grade 3. And for the late relapse, the vast majority of patients have a initial grade 2 and some grade 1. So there is two different categories of patients relapsing over the time. And we have to take into consideration when the patient relapse. Next slide. I give you an example of long interval free. Here you have isolated lung metastasis with 2 or 3 lung mets 4 or 5 years after initial surgery. One of my favorite approaches is there is no emergency and come back to me in 2 months with a new CT scan to discuss what is the best option for you. Next slide. And 2 or 3 months later, there is an increase in size, not in number. So here we were in a possibly curative situation. We have to be more aggressive in terms of local regional approach. So the surgery, a planned surgery of this lung metastasis could be discussed in multidisciplinary tumor board and with the discussion of an adjuvant chemotherapy in chemo-naive patient. Next slide. There is a lot of noise.
Ivo Henning, is it you who makes noise? Can you move off the microphone, please?
The other situation, it is a more aggressive sarcoma, grade 3. You follow the patient and you find some lung mets after 1 year after resection of localized disease. And if you have the same approach, the wait and see attitude, 2 months later, next slide, you have clearly a rapid evolution of this lung metastasis, not only in size, but only in number. So clearly in this situation, it's not the same like the case before, and we need systemic treatment and maybe planned surgery in responders. So you see here on these 2 examples, different scenario when you follow the patient, and you have to take into consideration before we treat the patient. If we are in a palliative situation, it is more or less this later case, because there is an increasing number in size. We are not in the same situation than before. Next slide. And these 2 parameters, the next slide. Next slide. These 2 parameters, the interval-free and the size of the lung mets are clearly independent prognostic factors. You see here in the review of 10 different ERTC trials in frontline, you see here the outcome of patient based on the interval between the initial resection and the lung relapse. See here, the best situation, it is a green curve when the free interval is more than 2 years between the localized disease and the metastatic situation. Next slide, more or less same findings with the size of lung mets. The best situation is when you have slow size of metastasis, less than 2 centimeters, confer to the patient a better prognosis. So when you combine these two prognoses, when you take into charge a patient, you give him a more correct strategy if you base your reflection on the number of lung mets and the interval free between localized disease and metastatic situation. Next slide. It is one of the reasons of the discrepancy of the results in advanced situation in the literature. And here it's an interesting French sarcoma retrospective analysis. It is more or less the same patient, metastatic patient, but with oligometastatic patient, means 1 to 5 metastases. On the upper curves, the patient receiving systemic treatment, but followed by local regional therapies. You operate the patient, or you treat the patient with RFR or surgery of lung metastasis. You can cure the patient. We are in not the same situation as the curves below, where the patients are treated with systemic treatment alone. So the impact of multidisciplinary tumor board, especially for this patient, is very important, because it is, as I mentioned before, the difference between a palliative situation and a possibly curative situation. So the goals of the patient, sometimes even as a metastatic patient, is try to cure the patient. So these curves highlight the discrepancy of the results in the literature when you compare doxorubicin versus doxorubicin, because in this patient we included patient with different presentation. Next slide. So it is the reason why all the different 5 large randomized trials in frontline testing monotherapy versus polychemotherapy regimen failed to demonstrate any impact on overall survival, especially for the last trial, the announced trial comparing doxo versus doxo plus olaratumab, because there is a mixed population of palliative situation and a more curative situation. Next slide. Another issue in the field of sarcoma, of course, is the histotype-driven treatment. We have more possibility of treated patient now, considering the histological subtypes. Next slide. And here I have summarized the different options. You know, I think you're all aware of this ESMO recommendation. We have trabectedin in all sarcoma, especially in leiomyosarcoma and liposarcoma, pazopanib in all sarcoma except the liposarcoma, eribulin in liposarcoma. And we have also non-approval drug for some histological subtype, leiomyosarcoma with gemcitabine or combination of gemcitabine dacarbazine, anti-angiogenic agent for alveolar soft sarcoma, weekly Taxol or weekly gemcitabine for angiosarcoma, and the old drugs like ifosfamide or dacarbazine. So, considering the histological subtypes, we can treat it today more and more different patients with different agents according to the histological diagnosis. Next slide. Rapidly, the approval agent in with chemotherapy in pretreated patients, the trabectedin in the upper side of the slide, eribulin, I think you are aware, it's approval agent. Next slide. But in contrast to the approval agent, we have also unapproval agent frequently used, not approval. It is the case of gemcitabine alone, a combination of gemcitabine docetaxel, gemcitabine dacarbazine, weekly taxol in angiosarcoma. These drugs are approval for other indication, but it is frequently used in soft tissue sarcoma due to randomized academic studies. Next slide. For example, weekly taxol for me, and I think if you have experience with angiosarcoma, you are also an experience with weekly taxol. I give you only this slide presented in ASCO 2020 with a combination of weekly taxol with an oral gut PGP inhibitor. I was not surprised, but 100% of this patient respond. It's a little phase 2, but weekly taxol is clearly the key drug, even in frontline, with a lot of different complete remission with or without surgery. So it is a non-indicated agent, not approval for angiosarcoma, but frequently used for different angiosarcoma, not visceral angiosarcoma, scalp angiosarcoma, and so on. Next slide. In the field of sarcoma, there is another important issue. We can make a lot of retrospective analysis. We have a lot of information based on prospective trial or experience of clinical routine practice. It is certainly a group of tumor where retrospective analysis can be done, sometimes highlighting the efficacy of some drugs. And I give you some example of the impact of retrospective analysis on clinical routine practice. Next slide. It is the case for the combination of doxorubicin dacarbazine, especially in leiomyosarcoma and in leiomyosarcoma. It is based only on retrospective analysis. But based on that, on more than 300 patients collected from different ERTC trials, you see here doxorubicin give more tumor shrinkage, more and a better outcome in terms of PFS in leiomyosarcoma comparing to doxorubicin alone or combination of doxo-EFO. Now, since maybe 20 years, it is one of my favorite options to give doxorubicin without any randomized trial. It is based only on retrospective analysis. Even in frontline, in neoadjuvant situation, when you have a localized non-marginally operable leiomyosarcoma, uterine leiomyosarcoma, it is my favorite option to give doxorubicin more than doxo-EFO. It is based only on retrospective analysis. Next slide. Next slide. And for another example of what we can do, you have these 3 slides highlighting the efficacy of anti-angiogenic agents in soft tissue sarcoma. Pazopanib, it is approval, but we have exactly the same curve with regorafenib in the French randomized trial, and lotinib in a Chinese randomized trial published 2 years ago at ASCO. We have exactly the same curve. But next slide, we have no idea of. There is no meta-analysis by histotype. We have no biomarkers of efficacy or toxicity up to date. So we have to make retrospective analysis. And next slide, we made that. Sylvia Stacchiotti have done this retrospective analysis, and even according to our experience, synovial is for me one of the major histological subtypes sensitive to pazopanib. So it is one of my favorite option, only based on retrospective analysis performed on prospective analysis. And based on this, on expertise in referral centers, we can maybe in the future introduce these guidelines based only on a retrospective analysis. Next slide. And based on that, we can build some phase 2 trial in specific histological subtype. It is a case of pazopanib in extraskeletic myxoid chondrosarcoma. So it is only based on some experience in some centers. So we have to make this kind of approach, academic trials with approval drug, but in some niche, to try to identify histological subtypes particularly sensitive to some agents. Next slide. It is exactly the same case for trabectedin. We have spent a lot of years in the field of sarcoma with trabectedin since now 20 years ago. Today, we know, based on retrospective analysis, we know that the L-sarcoma, leiomyosarcoma, and liposarcoma benefits the most from trabectedin. There is clearly a difference between non-L-sarcoma and L-sarcoma. It is based on a clinical routine analysis, expanded access program, based on more than 1,000 people. Next slide. The best example of retrospective analysis, it is the story of trabectedin in myxoid liposarcoma. It was a study implemented by Federica Grosso. Now, 13 years ago, we have collected only myxoid liposarcoma in each different referral centers, 44 patients, published in Lancet Oncology in 2007. And now it is one of the major agents in myxoid liposarcoma. And next slide, even in the guidelines, ESMO recommendation, in myxoid liposarcoma, high anti-tumor activity has been reported with early radiological tissue density change. So based only in a retrospective analysis. So there is a place to make this kind of approach in the field of this neoplasm in rare situation. Next slide. And today, I don't know if you're aware of this study published by, reported by Alessandro Gronchi at ASCO a few months ago, the combination of trabectedin plus radiation therapy in localized neoadjuvant situation. In localized myxoid liposarcoma, all patients respond with 14% of complete remission at the histological analysis of resected specimens. So this story was initially based on a retrospective analysis. Next slide. So the important things for retrospective analysis, it is especially in rarer than rare, than one case per millions of inhabitants to make this kind of retrospective analysis. Next slide. I give you some examples of what we do in the French sarcoma group. For example, for clear cell sarcoma, it's a translocated related sarcoma, translocation 1222, and we make a retrospective analysis, and we see here that with tyrosine kinase inhibitors, the median PFS is superior to doxorubicin. So today I give more and more TKIs, not in front line, but in second line, which is one of my favorites. I have some patients with a median duration of 4 years. So when you have a clear cell sarcoma, it is an option. So it is due to retrospective analysis in these rarer than rarer tumors. Next slide. Same thing in epithelial sarcoma. It is a rare situation. We don't know the best combination today in epithelial sarcoma. You see here is pazopanib is totally non-active and is anthracycline based or maybe cisplatin based. We'll try to collect in France today because epithelioid means maybe using epithelioid drugs like cisplatin gemcitabine, cisplatin vinorelbine. So we have interesting tumor shrinkage with this kind of combination. So there is a place to make retrospective analysis in this niche. Next slide. So it is a Jean-Yves Blais sentence made in Nina Axel lecture in last CTOS 2018. Major improvement in patient management were not necessarily the results of prospective clinical trials. Clinical trials were not always able to answer simple questions, and registry and prospective database provide important information. The reason why Swiss Sarcoma Network is very important to build, because more and more we have patients, including this database, more and more proof of concept we can develop in this neoplasm. Next slide. Same thing, same approach in the immunotherapy programs. When you see the different published up-to-date of immunotherapy, PD-L1 antibodies, the results are not dramatic. It's more or less like doxorubicin 20 years ago, when 10% of tumor shrinkage, 15%. So this study can be considered negative trials. Next slide. But when you see here, for example, I collect the different published study, and you see on the right, next slide, you see on the right part of the tumor shrink, the response, you see here alveolar soft part sarcoma. 3 shrinkage in alveolar soft part sarcoma. And so it is making this approach, you see here that maybe alveolar soft part of sarcoma, it is a rare sarcoma. 1% of sarcoma are an alveolar with a specific translocation X17. And next slide, when you try to include only one maybe immunosensitive sarcoma in one trial, but you see you have this answer. For me, it is one of the what we have to do. Make a retrospective analysis on prospective data and to try to isolate some immunosensitive histological subtypes. Here, 42% of tumor shrinkage in terms of partial response. Just published a few years ago with atezolizumab. Next slide. And we have in France an ongoing French phase 2 testing pembrolizumab in rare soft tissue sarcoma, and the results will be presented next ESMO in a few weeks. I have included 2 patients in this study with alveolar soft part of sarcoma. We have 2 major partial remission, and it is interesting, this kind of tumor, because there is no expression of PD-L1. It is a simple genomic soft tissue subtype with a translocation-related sarcoma, a low tumor mutational load. So we don't know why pembrolizumab act or atezolizumab act like that, but we have to review our thinking in this immunotherapy program to understand why this patient respond very well to immunotherapy approach. Next slide. So immunotherapy works in sarcoma. Next slide. But in immune subset or molecular subset of histological subgroups of rare soft tissue sarcoma. Next slide. The major advances in the field of sarcoma is the proof of concept in some molecular-driven treatments. Next slide. I make a resume. I think you're aware of this slide, but it's more or less the 5 molecular subtypes based on biological events. There's the group of gene translocation, 20% of patients, the group of gene mutation with GIST or tumor desmoid, gene amplification, well-differentiated or dedifferentiated liposarcoma, gene inactivation with the loss of ENEA gene, rhabdoid tumor, and a complex gene alteration with leiomyosarcoma, myxofibrosarcoma, and UPS. It is more or less the 5 groups of biological classification, not histological classification, but based on molecular alteration. And next slide, it is in this group when we found maybe an early causal gene alteration and we have the chance to have a drug. In general, you have a proof of concept. And it is a case of, you have put all in the list of proof of concept. It is not a case of in other oncology model. In breast cancer, we wait this kind of split. The only other models where there is some proof of concept, it is the lung cancer. But in the field of mesenchymal tumor, we have the chance to leave this era to when we found a target. It could be an initial causal gene alteration, and we have the chance to have a drug. We can register a drug, but it is not the case for some major advance. So it is a crazy moment, because you see here the gist. Of course, imatinib was approval. Even dermatofibrosarcoma, imatinib was approval in 2 little phase 2, in one in US and one in Europe, based on 50 patients. Nothing before. We know that there is a translocation with a autocrine loop of secretion of PDGFR beta, and we have a drug. So the drug was registered. It is the case for denosumab, but in other more recent studies, not randomized trial. We have trisotinib in ALK alteration, myofibroblastic tumor, inflammatory myofibroblastic tumor, is not registered. Its use of labels is also the case for anti-VEGFR in alveolar parts of sarcoma, and not only immunotherapy, but it's also pazopanib, sunitinib, or sorafenib agent can be used in alveolar sarcoma, rapamycin inhibitor in PEComa, and more recently, 2 studies I show you in the next slide. Next slide. We have this dramatic improvement of NTRK gene alteration in track 1, 2, and 3 in some different soft tissue sarcoma, but in bone sarcoma, in GIST, in infantile fibrosarcoma. The rate of complete response is dramatic, more than 90%, a long duration response, but incredibly, the drug was not approved today, was refused by FDA and EMEA, with the exception of infantile fibrosarcoma, but not in adults. So do we need a randomized trial to compare this kind of approach in agnostic rare tumor overexpress targets? We live in a complex situation. Health authorities have to change their paradigm for evaluation of these new agents. It's impossible for me. It's like imatinib in GIST in 2000 to come to randomized patient with an NTRK gene alteration between a placebo versus this anti-TRK agent. It became totally crazy. Next slide. Next slide. It's the same. Next slide. Good. We have exactly the same situation with pvns. Pvns, it is a benign, locally aggressive neoplasm due to genetic translocation. We have nothing in 2015, and today we have one drug, Plexicon trial, pexidartinib. William Tapp in the French sarcoma group published two phase 1/2 trials years ago with more or less 100% of tumor shrinkage, and we made a randomized trial versus a placebo, and you see the results. The uneven trials do really need a randomized trial when you have a proof of concept approach, when we have a target and we have a drug giving 100% more or less of tumor shrinkage. So we live a complex situation for registration. So today pexidartinib is approval in FDA, not approval in Europe, and if I remember, is not yet reimbursed. Next slide. Same finding with crizotinib in inflammatory myofibroblastic tumor. We validate this concept with a disease control rate with 100% with this ALK positive gene alteration And do we need really a randomized trial? I don't know. I'm not sure of that. So we have to change our we have to push health authority to change their paradigm to validate this concept without any randomized trial. Next slide. And in the field of GIST, FDA and EMA have approved the concept of if you have a PFS increase versus a placebo, the drug is registered. So it is pushing the authority to not only base the results on overall survival, but only on PFS. If you have this kind of curves in second line, third line, fourth line, with sunitinib, regorafenib in third line, and now ripretinib, it's more or less exactly the same results comparing to a placebo, the drug is registered. So it is our role to push authority to try to approve the drug based on some major endpoints. Next slide. To finish, some other, not proof of concept, but there is some efficacy signals in early stage trials with some other target, but we don't know if this target is the initial gene alteration, the causal event of this niche. For MDM2 inhibitors, we think that the amplification of MDM2 could be the initial target, but next slide, when you see the results, is not dramatic. There is something happen with, for example, abemaciclib in the differentiated liposarcoma. That is not the case for 100% of patients. So we have to make progress to understand why this CDK4 or anti-MDM2 works in some patients and doesn't work in others. So it's not clearly a proof of concept approach. Something happened, but we have to understand why. Next slide. The other items I would like to discuss with you is mesenchymal tumor and sarcoma in general. We have to push to try to include patients in early clinical trials. Next slide. And I give you one example of what we have done recently with this, we have these new malignancies named undifferentiated thoracic sarcoma, SMARCA-CAT inactivation. Next slide. I have included a patient on the left part progressing after doxo-EFO. We are in second line, nothing to propose. We don't know exactly what is this kind of tumor belonging to the sarcoma, BRAF deficient sarcoma. And I have included this patient in the pembrolizumab trial, and 2 years later, this patient is in complete remission. I have no explanation to give you why these patients are in complete remission, but we have to push our patient in new trials, early trials. Sometimes we have some good news. Next slide. And also, if I remember correctly, it's a Swiss idea in Geneva, if I remember the first report of immunotherapy approach in a chordoma patient. And today, you see some tumor shrinkage like that. I never seen tumor shrinkage before with whatever drugs, doxo, targeted agent, whatever, anti-VEGFR agent. With immunotherapy, also in chordoma, so we have to include patients in early clinical trials at any stage. Next slide. And we have to finish my talk to discuss, today we have a lot of different approach, and we have to deal with the patient perspective. Next slide. Next slide. Yeah, next slide. We have a lot of different drugs today. Next slide. So we have to discuss with the patient. We cannot exclude the patient in the decision making. We have a lot of different possibilities. So IV versus oral regimen, patient wish, activity of, we have to integrate the activity of the patient. include comorbidity, age. Next slide. Also, we have to deal with the patient, and next slide, and with the situation like COVID era. We have sometimes to modify our decision, IV versus oral, intensivity of the chemotherapy regimen. We have to take into consideration the wish of the patient, the era where we live. Next slide. So the one for the young oncologist today, there is approval drug with an approval dose, but we have a lot of different patients with different story, with different comorbidity, a young population, very elderly population. I have seen yesterday a patient with an angiosarcoma, 96 years old. You cannot have the same approach according to the presentation. So we have to have a flexibility, next slide, flexibility when you propose a treatment. Be careful on the dose according to the comorbidity, other therapeutic medication. Next slide, and I give you the example of the pazopanib story with a gastric acid suppression. You can have a negative impact if you, for example, here, if you combine pazopanib or maybe other anti-angiogenic agents with gastric acid suppression, you modify not only PFS, you modify overall survival due to the non-correct absorption in a basic area of gastric absorption when you combine pazopanib and gastric suppression. Next slide. We have to take into consideration that. And we have to define clearly biomarkers of efficacy and resistance. Next slide. It's an incredible world, the sarcoma. Here you have only radiological response, and you see here the beautiful response with denosumab in giant cell tumor. You have to need a calcification to see a tumor shrinkage. In other histological subtypes, next slide, you have a total necrosis like a pazopanib in the metastatic of synovial sarcoma. It is a resist stable disease, exactly the same dimension, but you see here total necrotic, so the opposite of the role of denosumab in giant cell tumor. Next slide. We have sometimes, like here, a complete remission with navelbin tumor in desmoid tumor, and we don't understand why. And next slide. Minor response tissue change with trabectedin in myxoid liposarcoma, for example. Next slide. And we have this sentence: absence of resist progression, defined prognosis in advanced active sarcoma in general. So you see here the different scenario you can have in mesenchymal tumor. So medical oncologists, medical radiologists, medical surgeons sometimes are more experienced than the radiologists themselves to try to understand what's happening in the body. So, but it's impossible in the field of mesenchymal tumor to have a reproducible, like in leukemia, lymphoma, and so on. It's a complex situation. Next slide. And we have today all these different drugs. When I start my career, I have only doxorubicin. Now we have a different agent. And today, when you see all phase 2 trial, objective response rate between 5 to 15% for all these drugs. And we don't know today, we have no reproducible biomarkers of efficacy resistance for any agents. So they have to be defined, try to find some prognostic factors to understand better what's happened inside the tumor. Next slide. And the best example for me, it was a STEP disease paper of Petit Prez at ESMO 2019 for immunotherapy approach, defined different sarcoma classification based on infiltration of lymphocytes, especially for the tertiary lymphoid structure with CD8, CD20, and another, to try to define group hot immunotherapy histological subtypes in red on the right part and totally cold soft sarcoma. Next slide. And when we make this kind of analysis in the previous phase 2 trial SAC 013 in US, if you consider the responding patient, 50% of the responding patient with an objective response rate are in the right part of this classification. So tomorrow we have to identify histological subgroup of sarcoma highly predictive of chemosensitivity, sensitivity to pazopanib, sensitivity to prolactin, and sensitivity to immunotherapy. It is the next scenario. Next slide. So in conclusion, challenge in 2020, we have to treat the right patient in the right place at the right time, with the right diagnosis, in histological subtypes of rare soft sarcoma, with the right treatment sequence, with the right individual adapted schedule, in accordance to the patient wish, and maybe sometimes with the right lower benign hue. Next slide. And it is urgent to individualize reproducible biomarkers of efficacy for the reason I give you, with the exception of proof of concept therapy. And I finish my talk with the sentence of Paolo Casali. Next slide. Targets have to be targeted, but sometimes tumor cells do not understand what human beings are doing. Thank you very much for your attention. Now we
great applause. Axel, thank you very much for this excellent overview and also your thought-provoking issues that you raised. I think it was a great introduction. So I would like to open the questions and the discussions. So probably now you unmute your microphones and please go ahead and speak up. Or maybe we want to start with Jean-Yves Blais. You are still among us, and maybe I would like to pass on the word to you and asking, how do you comment and see these issues from your perspective?
Well, I think Axel said it all. I think we're in very exciting times for sarcoma, where we are really starting to treat the tumor on the basis of our molecular understanding of the disease, and probably as concluded in centralized expert places with adequate molecular characterization with the best specialists. I think one of the main problems that we are going to have probably in the future, given this fragmentation, is how do we cope with our capacity to deliver the treatment to the patient, given the reimbursement strategies, and how do we do clinical trials in very rare subtypes. I was, as Axel mentioned, impressed by the lack of reimbursement of larotrectinib in France. Actually, it's not reimbursed only in France, it's available elsewhere, but and avapritinib is probably going in the same direction. I think we cannot do phase 3 trials for this disease. We cannot do randomized phase 2 trials. So really the regulators have to listen to the experts because this is going to be the way we do oncology, and in particular sarcoma oncology for the future. But I think Axel summarized it all.
Any other comments?
The problem is also the price. More we fragmented the tumor, more we have a niche, and more the price increase. To give you an example of larotrectinib in US, it's more or less $300,000 for 1 year of treatment. So it became crazy, the drug. If you treat only 10 patients per year per country, so it is the big issue. more we have a fragmented tumor and more the price increase.
So the way to improve the situation, I mean, you point towards regulation and towards, let's say, improving the word of the experts. So how can that be accomplished?
I have the impression, I may be wrong, but I would really like to know what is happening in Switzerland. I have the impression that the word of the patient is more listened to than the word of the doctors, including the experts. So maybe the patient should express themselves more in front of the politicians.
I think from my perspective at least, it's comparable to all neighboring countries as well. And I only can agree with you. I think the patients would have a very strong word. In Switzerland, there is a patient organization, but I think as everywhere, of course, there is a lot to be done too. But I agree that, let's say, teaming up between the patient and the physician might impact the regulations very much so. I probably need to focus even more there. So, how is that in Austria, Dr. Scandera?
It's very difficult to get the medication here. All the phase 2 trials, for example, I do not have the access to the drugs. So I have to ask the pharma industry if they are able to give me the drugs for 2 months. And when the patient responds, then the insurance is going to pay for the drug afterwards. But we have to prove that the patient is going to or is responding to the medication just in the 2 months, in the first 2 months.
Yeah.
In Germany, for example, I know that they get it free when somebody is specialized on soft tissue sarcoma and he decides to give a patient, for example, immunotherapy, the patient will get it easily. It's not that such a problem like in Austria.
So I think that's the same thing in Switzerland, or let's say Felix or Tamara or Ralph or Stefan, Abby, you want to add something in this respect? You need to unmute.
I mean, at least in children, usually it's possible to get the relevant drugs. But the variety of sarcomas are usually smaller in children, and therefore it's not such a big issue, even if we have to apply many of these drugs as compassionate use.
Do you have different rules according to the cantons in Switzerland, or is it more or less the same rules in all cantons?
Basically, it's the same rule in all cantons, but we have many different insurance companies, and every insurance company handles it differently. That's the bigger problem.
Further questions? Regarding the talk of you, Axel, you mentioned in the beginning, how important the pathologist is, and we have many pathologists among us too. What was interesting, you showed, let's say, this diagram pointing out that, let's say, per year there are 10% of discrepancies with a diagnosis. And the question is, it seems to me that it remains constant over a decade. So the French sarcoma network being organized as, let's say, as wonderfully as one can, what is the explanation that this remains constant and it's not being improved? Do you think it's inherent to the complexity of the diagnosis, which we just cannot more improve, or is it just the awareness that could be improved?
I
think it's difficult to answer to your question. We observe the same. We are intrigued by these numbers as well. I guess that probably there is an inherent degree of complexity to gather the patients at the right time, which makes it probably one of the explanations. I think it's fair to say also that with the database we are as exhaustive as we think, but we have not yet. We are in the process of doing that. Match the database that we have created to the National Social Security System database. With that, we will really have a proof of the exhaustivity, because that may be also an explanation that we are not exhaustive actually, and there are still some patients who come to us late.
Oh, very interesting. Any other questions from the audience?
I have a question concerning review of pathology, which is, of course, highly relevant to get the right diagnosis and have a proper treatment. But to have a review board, I mean, is it just one referral pathologist or one pathologist who looks specimens, or is it a board? Because, I mean, even specialist pathologists can be on the wrong side. You know that from earlier trials and experience.
How do you handle this? We have, as you know, we have 26 referral centers in France. When in three large double review in the three large centers in Bordeaux, in Lyon, and in Paris. Sometimes, for rare situation, when the local pathologist referent of sarcoma have some difficulties, they have every month a meeting between them to have a third lecture. So it is a selection of maybe 5% of all sarcoma where the diagnosis is not so easy, even for a referent pathologist. There are every month meeting between all the referent pathologists to make a third lecture.
So maybe could I comment also on this topic as a pathologist? The problem is with this 10%. It may be pathology is kind of interpretation. It's not like, reading a value of 3.5. So I think you kind of measure it on pathologists by, it may be that it's, inherent to a human nature. So if you take, like all oncologists and all radiologists and, compare it from the best centers, you would also get this equality in the opinion. Also for pathologists and radiologists, it would be perhaps a different percentage.
Yeah, I agree.
It's art and science also at this level, and so I think maybe something inherent to the human nature in this respect.
I agree with you. One important thing also is every Monday in our tumor board meeting. The pathologist comes to us to assist and to see radiology, to see the evolution of the patient. So pathologists are really present to see also if there is no large discrepancy between what thinking about oncology, medical radiologists, and so on. So the role of pathologists within the tumor board is very important, not only behind their microscope.
May I add something? Sorry.
Please.
We in Austria, for example, for the detection of fusion-driven sarcomas, we use our pathologist uses the Archer Fusion Flex panel. And it's something that makes you really sure that you have a fusion-driven sarcoma, and the testing is positive for that. So at least for those sarcomas, we have for sure a diagnosis that is accurate.
Well, this is standard, so this is nothing. You know, it's we use molecular pathology. Pathologists use molecular pathology less. Currently, as you know, before we used immunohistochemistry, so this is absolutely acceptable, basic. But there are always, you know, the entities which are difficult, which they don't have fusions, and
of course,
it may be difficult on a core biopsy. So this is you know, this is very important.
Yeah, that's tricky. Yeah, I agree.
It's very important that you absolutely. You know, pathologist is a clinician, so that's very important. I appreciate that that you mention it, and that's how we feel. You know, that's how we feel. So we also appreciate it if you see it like that. So, and this is, you know, this is interpretation, and somebody, you know, somebody more used to interpreting minimally invasive samples as core biopsy or cytology looks at the, you know, has a different angle as somebody who always, you know, looks at the, I don't know, excision biopsies, and so this is art and science, and this 10%, I'm afraid it's not, you know, kind of particular to pathologists. I'd rather if we measured your performance, we would probably end up with a similar number.
Very good. Thanks so much. I think clear pathology is extremely important. Other issues, questions to Axel? Then maybe I want to bring up just one more point, indication to chemotherapy. I think you made a great point. It needs to be individualized. And if you go in this direction, what's going on the international level? What kind of trials going on? Which parameters are, let's say, looked at? Can you update us on this?
In what? In advanced disease or in local disease?
Well, maybe both.
Well, I think we can make a new webinar on the role of adjuvant or neoadjuvant chemotherapy, because it is a complex situation. The most important things I give, I remember, if you remember what I mentioned before, it is to try to have an earlier resection. So if you consider that it's complex to operate the patient to render with earlier resection, and you have to discuss with in multidisciplinary tumor board, radiation therapy, chemotherapy. The objective is to, if you have a perfect earlier resection, you can operate the patient upfront. If it is a complex operation, it is better to discuss induction treatment than adjuvant treatment. An adjuvant treatment do not salvage an incomplete R1 resection, R1 or R2. So it's better to have this idea in head earlier resection. So best discussion is when your patient are here with a tumor with the correct diagnosis.
I think that's a very good final word, but any other comments to this? Well, then I think I take it. Again, Axel, so many thanks for this huge contribution. I think it was a well-invested time, at least for me, I hope for everyone. I thank you everyone to take your time to be here, to share, and hopefully you will prepare to be here again on 29th of February when Alessandro Gonchi will talk about the retrospective sarcomas. And
in October.
If there are any questions, comments, or suggestions, please let us know. In this respect, have a great evening, and thanks so much.